Great. Good evening, everyone. I welcome you all on behalf of Gender Collab and ICRW Asia to this virtual learning event on women's leadership in health. You are here because you either know ICRW or Gender Collab. ICRW, for 47 years, the International Center for Research on Women has set the global agenda for gender equity, inclusion, and shared prosperity with its action-oriented research and solutions. Their research and programs, advocacy and policy, and private sector teams focus on economic opportunity and security, health and reproductive rights, gender norms, and climate action. I represent Gender Collab, which is a community of practice that brings together partners to work towards advancing gender intentionality within the health system. Gender Collab is anchored by Oxford Policy Management and facilitated by Quicksand, with support from the Bill and Melinda Gates Foundation India office. Presently, the community has 37 members from 16 organizations, and among the few things that we've been doing that include creating this virtual repository, I'll request Ria to share the link to our website. We've also been hosting virtual learning events that become a mode of bringing people from different parts of the world together on topics that we believe are important to discuss. Welcome to one such event today where we talk about women's leadership in health. Now, before we begin, we'd just like to go over some ground rules. We are recording this session for the process of documentation. Do let us know on a side message to Ria if you'd not like to be quoted or recorded. We will be producing text-based and visual documentation with this. We'd love for you to introduce yourself and also mention your organizational affiliation. I'm going to request Devika and maybe Ria, if you can mute people. Okay, cool. I'll just pause for a second. Thank you. Okay. Great, thank you. Please introduce yourself and the name of your organization in the chat box. We are keeping time, so Deepthi from OPM might intimate you and let you know in case if you're going over time, and feel free to add your chats, add your comments and questions in the chat box. For the day, we will be starting, which is this right now. I'll briefly introduce what's going to happen in the session and the speakers. Then we'd have some opening remarks from Dr. Priya Das. Priya will then invite the three speakers to share their initial thoughts based on prompts that she will ask them. Then we'll talk about entry points to enabling women's leadership, followed by a 30-minute Q&A with Deepthi. And we'll have Dr. Pranita Achyut from ICRW doing the closing remarks. Great. Great. We're really, really glad that our speakers could join us from across different time zones in the world. And many of these are also people whose work is already featured on the Gender Collab website. So we're really glad to have them here. I'll keep requesting Ria to keep muting people as they come. And we will remember to change this next time. Great. Thanks, Ria. Dr. Rosemary Morgan comes from the Johns Hopkins Bloomberg School of Public Health in the US. She's an associate scientist there. Dr. Morgan has expertise in gender analysis, and intersectionality, and works as a gender specialist on a number of health and health systems projects. A lot of her work is already on the Gender Collab website, so I'd really encourage you to already see it. And we're really grateful that Dr. Morgan is here with us. Dr. Rupa Dhatt from Women in Global Health, WGH India and USA, is the executive director and co-founder of WGH. She's a passionate advocate for gender equality in global health and is a leading voice in the movement to correct the gender imbalance in the global health leadership. She is also a practicing internal medicine physician in Washington, D.C. Determined to build a movement to transform women's leadership opportunities in health, Dr. Dhatt co-founded Women in Global Health in 2015. WGH drives change by mobilizing a diverse group of emerging women health leaders, advocating for governments and global health leaders to meet commitments made and holding those leaders to account. Welcome, Dr. Dhatt. We also have Ms. Sapna Kedia. Hello, Sapna. Sapna is from ICRW and Women in Global Health India chapter. Sapna works as an assistant director for gender and social development at ICRW Asia office. At ICRW, Sapna leads and supports research and programs on issues of men and masculinities, sexual reproductive health and rights, as well as gender governance and public policy. And as I said before, she's a founding member of WGHI in WGHI. We also have Dr. Priya Das moderating the session. Dr. Priya Das is the gender lead at OPM, or Oxford Policy Management India. Priya has over 20 years of experience working on policy and research in the development sector in India. Her areas of expertise include women and girls empowerment, gender-based violence, qualitative and action research, and training and capacity development, strategic thinking and planning. Priya holds a PhD in social anthropology from SOAS and is currently gender lead at OPM. Welcome. And with that, I would kindly invite Priya to share some opening remarks and invite us into this conversation. Over to Priya.
Who's the anthropologist?
I don't know. I missed it.
Okay, so hi, good evening, good morning, good afternoon, as the case may be. We're very, very pleased on behalf of OPM and my colleagues at ICRW to welcome you to the second virtual session. And I'm particularly pleased to have such an expert set of panelists speaking to a very important issue today. We are all aware of the huge sort of gender deficit in women leadership in health. And it's an emerging and growing issue. And the set of panelists we have today are some of them who are really sort of either at the forefront of advocacy to enable gender parity in women leadership in health, are researching, providing evidence, tools, and means to integrate gender into the health system. And we hope that with this panel, we are able to take away some, actionable insights and learning that we all can sort of try and integrate in the work that we do in promoting gender integration in health systems, both for providers as well as for clients. And I know that many of you are really looking forward to this panel. So without taking more time, I'm going to invite the speakers one by one to share their insights with us. So I'm going to invite Dr. Rupa Dhatt first. We are all aware, as the sort of co-founder of Women in Global Health, she's been at the forefront of advocacy for enabling better women's leadership in global health. So the key question that I'm going to invite her to share her insights are on what is the status of women's leadership in health at the global level? What are some of the key learning, given that WGH, is prolific in generating evidence in that area? If you could share some of your insights in what the status is currently in terms of women's leadership in health globally, as well as what are some of the challenges in enabling better gender parity there. Rupa?
Great. Thank you, Priya. It's really wonderful to be in such an incredible room and to be with colleagues that I recognize. So I really am looking forward to hearing from them as well. And rooms like this are an opportunity for all of us to learn. So I'm very much here to learn from all of you too, as this our thinking at Women in Global Health it continues to go through evolution, as shared in the introduction. And if we can go to next slide, we were founded in 2015 by 4 early career women, and I'm one of the 4 early career women. And I'd say most of the time I'm in the U.S., very little in India. So just wanted to clarify, we have the Women in Global Health India chapter leader on today's call, and you'll be hearing from her, Sapna. So just wanted to clarify that. But we found ourselves in 2015 really asking the question, how is it that in such a talented field, such as the health sector, we have so many incredible women, we don't have a pipeline issue, women enter into the health sector in high numbers. But when you take a look at leadership at the highest levels, and in this case, we were looking at global health leadership in academia, in policymaking, and in global health institutions, we were seeing that women were incredibly underrepresented decision makers at the World Health Assembly, and so this was the issue that we really felt needed to be addressed, and for us to launch a solution-oriented approach. And so we decided, to drive societal change, it takes collective action. So Women in Global Health launched in 2015 as a global movement to challenge power and privilege for gender equity in health, with a specific focus on leadership. So it's that problem that, and I've been asked to speak on the status of women in health. And as a physician myself, I have to say that this pattern was not only in the hallways of the UN or the highest levels of decision making, it's also replicating itself in hallways in our health systems, whether that is at very much of the community level or in tertiary centers, academic training centers. Women are often entering in high numbers into the workplace or into training numbers. But when you take a look at who's making the decisions, who is the dean or the chair of the department, who's being recognized, been given awards. And I've had the chance to work with Dr. Morgan on a lot of this early research we did too. So it's great to have her on this call. And again, that pattern continues to replicate itself. And so I'm really glad that we're having this conversation from a health systems point of view, because that is where the impact is felt day to day. When you lose out on women's expertise, they're the ones delivering health, but they're not the ones making decisions. We are all losing out, not only because it's the right thing to do, but the expertise that women have in being the primary patient care providers, we're losing out on that. So that, it's fundamentally about getting to health equity. So I'm going to answer the question that I was asked to, and very mindful of time. What is the status of women's leadership? Women in Global Health, next slide, please, did and this covers some of the policy areas that Women in Global Health works on, not just women's leadership, but we work on areas in the pandemic preparedness, response, health emergencies, universal health coverage, movement building, and really working on improving the conditions for women health workers. That's a core area of our work. Next slide, please. And Women in Global Health has been generating evidence on this area since 2019. We released with the WHO our landmark report called Delivered by Women, Led by Men, a Gender Equity Analysis, where we baseline what was the status of women's leadership in the health sector. And in that year, we found that 70% of the health workforce are women. But when you take a look at the highest levels of leadership and aggregate them in academia, private sector, and policymaking, it ends up being about 25% of those leadership roles are held by women. And since then, we've done a series of reports that look into different areas, and we'll be talking about what is impacting women's leadership. We've talked about them not having access to appropriate personal protective equipment. We've talked about the topic of sexual harassment being a top driver, and have had reports that look into this pay inequity issues and unpaid and underpaid work. So I'll be covering some of those themes, but you can all check out our policy papers. They're available on our website. And so
we only submitted.
No worries. I think someone's audio there. And this year we did another reflection of the status of women and leadership in global health and released a report earlier this year. So next slide, please. And in this state of women and leadership in global health, for the first time, we did deep dives with our country chapters in India, Kenya, and Nigeria. And so this report highlights both what's trends globally, but doing deeper country dives so that we understand, are there similarities? Are there, uniqueness to these realities in particularly those countries? So next slide, please. So some of the findings we found between the research we did in 2018 to the research in 2022, we have seen that overall the pyramid has not changed, and in some areas it's actually worsened. And this is the leadership pyramid, women's leadership pyramid in global health. So what you'll notice is the base shows majority of the patient forward facing roles like nurses are women in the 80 to 90% range. And when you go into policymaking, academia, private sectors, those numbers quickly dwindle down. So we saw particularly declines in female ministers of health. They went from 30% to 25%. We also saw that the World Health Assembly delegations, which are led by women, the ones led by women went down from 27% to 23%. And then the one area where we did see an increase is the private sector, where Fortune 500 healthcare companies led by women increased from 5% to 12%. And if you look at the trends across the years, I'd say the first two numbers on policy making, they fluctuate around the 20 to 30%, whereas the private sector, we have seen a steady inclination, just so that you have some context on trends. Next slide, please. And what we are saying at Women in Global Health is that women have lost ground in health leadership during COVID-19. Some places where it was very apparent, as we looked at the WHO Executive Board meeting last year in January 2022, sort of the peak of pandemic response negotiations. And we found that, and the executive board is comprised of governments, member states, and they appoint who they want to be in these roles. Only 6% of the executive board members were women, and that was down from a high in 32% in 2020 before there was a pandemic. So it just shows you that once a topic becomes of high priority in a government and of importance, very quickly those roles are replaced by men. And then a study that we that our team did in 2020, we mapped out 115 national COVID-19 task forces, especially in the very early days, and found that 85% of those were majority men. There were dozens of task teams that had all men, even if they had numbers of 10 to 20 on the task team. It really didn't matter which region you were in. There were some regions we saw a little bit more lack of having gender parity, but even in high-income countries, we were seeing all male COVID-19 task teams, or nearly all male. And just to kind of quote Dr. Yodi, who is the WHO Special Envoy for COVID-19, she has said, "It slapped me in the face so much that during this pandemic, the fact that global health leaders are men. A lot of women tend to be number twos, so they don't quite have the decision-making power and the voice." Next slide, please. Some groups of women are more excluded from health leadership, particularly in low-income countries, and I know my colleagues here will talk more about this. Those that have lower levels of education, literacy, they're restricted in the level that they can enter the health workforce. And despite them having critical roles in delivering primary health care as a community leader, women community health workers are typically excluded from formal leadership roles. Often community health workers will come from a lower caste, lower socioeconomic background, and migrant workers, ethnic minorities. So it's usually those that are the most marginalized in their societies that are subsidizing healthcare for all and are really having leadership roles. Next slide, please. across contexts and cultures, women experience common challenges. So as mentioned, this was the first time we were able to do a comparison between Nigeria, India, and Kenya. And despite the differences in culture and socioeconomic context, we found there were common challenges. Qualitative data from 100 respondents confirms action needed to address powerful gender norms and biases that discriminate against women in their homes and workplaces. So I'll be sharing some of those quotes here. Next slide, please. Gender norms and roles limit women's participation. So for example, in Nigeria, a doctor said, our culture environment does not really support women as self-starters. We are always taught to follow instead of lead. It takes a lot to overcome that. In Kenya, if you don't have a spouse who is supportive, you will stop working. We have had women who stopped working because the spouse said, no, you can't go here, you can't go to work. In India, since childhood, I've only been heard this is as gospel truth. Women's primary job is to take care of the household. It is difficult to keep challenging this notion, even internally, when everyone around you keeps saying this. When I got married, my mother-in-law very explicitly told me that my job is to do seva for my husband and my future son. And we're taking the time to highlight this, that regardless of the country and the cultural context, women universally are feeling the gender norms that are defined from before even a child is born. There's societal gender norms that start in childhood, and they continue to face that even if they are highly educated. Next slide, please. Women's experience discrimination linked to motherhood penalty. For sake of time, I won't read all of these quotes, but what it really highlights here is that regardless of whether a woman has a child or is providing a care responsibility, it is assumed that she will be having children and therefore not worth investing into in career trajectories. And this is the motherhood penalty, and it presents in many different ways. It presents when one doesn't have a child and when one is pregnant. We've had some of the women say that, when they came back, they found that their job was replaced by somebody else, or they were told to go further remote, that they're pushed out, even if they do want to come back into the workplace. So these are some of the motherhood penalty narratives that are presenting themselves. Next slide, please. Women, gender stereotypes around leadership deter and penalize women. So for example, women are often called emotional several times, and they have to walk the tightrope. They're told that they don't have the appropriate qualities and diminish their voice. A testimony from a clinical officer in Kenya: the women you find are the ones being told to serve tea because it's what society is used to seeing them. Even when a woman is in leadership position, they're told they cannot speak too much, you cannot be assertive, just because of society. So they're not able to exercise their platform with informal leadership roles because of the gender norms. Next slide, please. Governments have made global commitments to gender equality in decision-making, but these will only drive change when implemented. And I know we're at time, so I'll be wrapping up here in the next one or two slides, but wanted to drive home that even where there have been policies where there are gender quotas, what we have found is that, or if governments have made commitments to the Sustainable Development Goals or other gender equality targets, they're rarely implemented. Our research confirmed that global commitments are not implemented fast enough and not with accountability at the national level. One really powerful testimony that came as an example in India, where there's a Prevention of Sexual Harassment Act to address workplace sexual harassment, but it lacks teeth. A testimony said, I went to my supervisor with my complaint of sexual harassment. Not only did he overlook my complaints, but I was harassed to such an extent by the administration that I had to ultimately quit the hospital. And when women leave a workplace and start at another workplace, they often are labeled as troublemakers, and their career trajectory projection is also impacted. So it's not only about changing workplaces, but this carries on with you and has a toll on the career pathway. Next slide. And so finally, in closing, what I'd like to say is that gender equal leadership at the national level will feed female talent into global health leadership. We highlighted some examples from the national context, but as long as societal gender barriers are not addressed and systemic biases against women continue, men, vast majority of health leaders at national level will continue to dominate global health decision making. So for us, the linkage is very apparent. We can advocate at the global health or at the global level for global health leadership roles to go to women, but we know that it's very much connected to what's happening in the national context. So if women are not getting the most prominent positions there, we're going to continue to see men rising and dominating the global health space. So it's very interlinked. So I know this is just part one of the conversation. Turning it all back to you, moderator. Thank you.
Thank you. Thank you, Rupa, so much. And I think the presentation, like, very comprehensively at a glance and also quite disturbingly tells you the extent of deficit really at the different levels in terms of women's leadership in all areas of the health sector. And moving on from you, I wanted to sort of, we get a sense of the status of women's leadership. But interestingly, when OPM conducted several KIIs with experts across the globe on trying to understand women leadership in health, one of the quotes that came up very often was that it's absolutely necessary to have women in leadership, but it is not sufficient. One needs to really think of gender responsive and gender transformative leadership. And that's the question that I'm taking to Dr. Rosemary Morgan to share with, I mean, of course, like Rohan introduced, you've done extensive research work, developed tools, etc., to integrate gender in health system and have co-authored the book, work with Rupa. So if you could sort of share your insights on really unpacking the statement of not necessary but not sufficient, and therefore a better understanding of what is gender responsive leadership or transformative leadership. Over to you, Rosemary.
Thank you very much, and thank you for having me here. I'm delighted to be here to speak with you today. I will go ahead and share my slides. So if you can stop sharing the screen. Oh, there they are. Okay, great. Thank you. So today I'm going to talk about gender transformative leadership and also, actions on the path towards gender transformative leadership, because you're right that gender parity is often not enough. We need to think it's not necessarily about equal representation of men and women, it's equitable representation of men and women and other diverse groups within that. And we need systems and structures in place in order to get there. Next slide, please. One thing I wanted to start off with is we are talking about the health system, and it's important to recognize that health systems themselves are social systems and reflect and reinforce the cultural and social characteristics and norms, values, beliefs. They often reflect the social order within their societies. So the inequities that you'll see in society, in the community, and other levels are going to be reflected in the health system. And you saw that clearly in Dr. Dutt's presentation. And then when we're talking about health systems interventions, often people go right towards the outcome of health systems. How do we improve health outcomes? How do we ensure that health outcomes are equitable? But we argue that you can't have equitable outcomes without having equitable inputs and processes. So thinking about how the health system itself is a system, how does inequity manifest in the health system? And what do we need to do to change that with the ultimate goal, yes, of improving health outcomes for everybody? Next slide. So one way we think about this is because gender and equity is very much reflected within the health system with all the different within the health system's building blocks. Is how can we move towards a gender responsive health system? How can we address gender inequities within all components of the health system, including within leadership and within governance. And so a gender responsive health system is one in which takes into consideration the intersectional needs of everyone, women, men, and gender minorities, in the development, delivery, and management of health systems across all health systems areas and levels. Next slide, please. I want to take that a step further. We need gender responsive health systems, but thinking about what about gender transformative health systems? What about gender transformative leadership? What does that look like? What would that mean? This definition comes from UN Women, and they define gender transformative leadership as seeking to cultivate individuals, including decision makers, who empower themselves in their organizations to pay close attention to gender power structures and discriminatory practices, both formal and informal, in order to advance gender equity in their organizations, as well as in the communities and constituencies they serve. So first of all, having a recognition of gender power structures and discriminatory practices, and then trying to challenge and change those. Next slide. But let's unpack gender transformative leadership a little bit more. So gender transformative leadership, it seeks to address discrimination, bias, and inequities in the system at its core. And it can be applied to all levels and everybody. It can be applied to decision makers, the institutions they work in, and to the health system itself. The Women in Global Health have come up and have developed with a set of qualities that really defines gender transformative leadership. And these are outlined in the book that Dr. Datta and I have co-edited on women leaders. So these qualities include being grounded in a vision of gender equality and women's rights, being challenging privilege and imbalances in power to eliminate gendered inefficiencies and rights, deficiencies that undermine global health, being intersectional in how we do that, understanding that not all men and not all women's experiences are going to be the same. Next slide. It includes making sure that this approach is not for a woman only, it's for everybody. And it applies to leadership at all levels, from the community to the global. It recognizes that different forms of leadership, such as thought leadership, which are not based on simple hierarchy and people management. So there are different forms of leadership to recognize. And it allows for different starting points and contexts, but prioritizes inclusion of the most marginalized and excluded, and assumes that gender equity equals smarter health, global health, and that gender transformative leadership is necessary for the achievement of all global goals in health, including the Sustainable Development Goals. So those who seek to be gender transformative leaders aim to leave no one behind, not only in access to health, but also in leadership and decision making. Next slide. This here comes from UN Women. It's the Women at Work framework. And I find it really helpful in thinking about what is it that we're trying to change when we're within institutions and organizations, including the health system, when we're talking, and particularly when we're talking about gender transformation. So you can see here, you've got your individual change and the institutional systemic change, and then informal and formal. And in that different quadrants of things that we're trying to change, of thinking about access to resources and opportunities, our consciousness, our knowledge, skills, informal cultural norms, and formal institutions. So a gender transformative approach looks at all of this. You have to look at all of it. You can't just take one quadrant in an intervention. We have to be multi-sectoral, multi-level in our approach and in our interventions. So explores how formal, such as policies and laws, and informal norms and workforce cultures, systems present opportunities and barriers to achieving gender equality in health sector organizations. So I find this really useful in mapping out what is it that we're trying to challenge and change within our health systems to improve inequity at all levels, including within leadership. Next slide. But there are challenges, you know, this rhetoric we've been going on for a long time, and there's a lot of both formal and informal resistance. We often see a lack of political will and commitment to address gender inequalities at all levels, including within leadership, often because through the work that we're doing, we're challenging the status quo and stereotypes of who and what qualifies to make a good leader. And people often get uncomfortable when you are challenging the status quo and the hierarchy, and thinking about, you know, that you're potentially taking power away from somebody to give to somebody else. But it's not a zero-sum game, you know, when we're talking about this. In some contexts, health systems are just not adequately equipped to respond to gender differences at all levels. Gender is often overlooked in human resource planning and policy making, which is a critical component of leadership. And we still, to this day, and Women in Global Health have gone a long way in helping us improve this, but have a lack of disaggregated data by gender and sex, and a need for an intersectional lens within that. All right, so there's a lot of challenges, and gender parity is still very far away. Next slide. So what can we do? You know, what are some practical things that we could do? And we'll talk more about some of these when we talk about specific entry points. So first of all, being thought leaders, shifting the way women are perceived in the health workforce, not just recipients of care, but as agents of change. You can lead the way in implementing and providing funding support for gender transformative approaches. Advocate for diversity in leadership. Advocacy is so important. And adopt gender mainstreaming approaches to address gender inequalities within the health workforce. But let's break this down a little bit more. Let's make this a little bit more practical. So thinking about going towards a gender responsive and transformative leadership approach, we first need to be gender responsive, right? We need to think about, you know, what needs to happen, and some ways to increase representation within our organization to integrate a gender lens include, first and foremost, conducting gender situational analysis and developing a gender action plan, evaluating criteria for appointment or promotion to ensure that they do not replicate existing biases, providing supportive supervision to everybody, ensuring flexible working arrangements as needed to account for women's dual care responsibilities within the home and workplace, having a zero tolerance policy and approach for harassment or discrimination, including sexual harassment. So developing and disseminating sexual harassment policies with clear accountability structures, ensuring equal pay structures for men and women, and if helpful, developing a quota system for appointment and promotion. There is some develop quota systems. There's different arguments about it, but in some cases they are a step that some organizations have changed to help to try to challenge and change some of this. Next slide. So as a first step, conducting an organizational assessment, you know, and developing an action plan, I think is a really important first step to identifying challenges and barriers, and then identifying solutions to those. So the following activities, and this list is absolutely not exhaustive, can be part of a gender situational analysis and action plan. So developing, and as an organization, we can develop and disseminate existing guidance on where we currently are promoting gender balance and diversity, and where are the gaps. What are we currently doing in this area? We can identify the systems and structures which impede women's career advancement and promotion. We can develop and implement strategies to address any identified gaps and impediments, and integrate gender lens into all relevant policies, including recruitment and payment structures and sexual and gender-based discrimination and violence. It's not enough to talk about this. We have to put it on paper and put it into practice. We need to make sure it's embedded into our systems and structures within our organizations. And in order to do that, we need to understand the specific issues and then develop clear action items to respond to those. Next slide. I wanted to leave you with a few resources to help you on your journey. But the first is the MAGE website. This is a project that we're leading here at Hopkins. And this is, you can search, it's for monitoring and action for gender and equity. You can search for different gender tools here to help. Next slide. This is a resource from Trapaigo. It's an excellent guide to facilitate a training on gender transformative leadership. It's particularly a participatory toolkit for health workers and has all the information in different modules for you to use to do this training. And then lastly, the book that Dr. Dad and I have co-edited on women and global health leadership. It's unfortunately not open access. Ironically, we weren't able to get the funds, but if you are interested in exploring this book, you can reach out to us. And in it, we have stories from women leaders. We've got chapters on evidence from women leaders. And there's the description and discussion on gender transformative leadership is also in there. So thank you very much.
Great. Thank you so much, Dr. Rosemary Morgan. I mean, you really took us from understanding what the fundamental and structural level changes need to be in terms of norms, in terms of political will, etc., to some really, really very actionable, practical things that one can begin to do. And of course, and thank you so much for sharing the resources. I'm sure Gender Collab community will really benefit from using that. And on that note, I just want to now invite Sapna from ICRW. It was interesting that Rupa in her presentation spoke about, unless we kind of build it up nationally, we are going to see that deficit in the global leadership. And so from moving on from understanding the global status to unpacking ideas around gender responsive and transformative leadership, I wanted to invite Sapna to really share from ICRW's work that she and her colleague have been leading to understand what has been the women's leadership in health in the Indian context of which ICRW conducted. And she will be sharing with us some of the key insights from those findings. So welcome, Sapna.
Thank you so much, Priya. As we go through my presentation, it's going to resonate a lot with what Rupa shared and what Rosemary shared. And in fact, some of the things that Rupa and Rosemary mentioned, a lot of that was also shared by our participants. So I'm quite excited to share our findings. I just really wanted to acknowledge my colleague Radhika Uppal and her support in conducting this study, and also Shabi Anwar, who was a consultant and who helped us with the data collection and analysis. Next slide, please. So in 2022-2023, ICRW, in partnership with GH5050 and APHRC in Kenya, we conducted a formative research study in India in the health sector to inform Gates Foundation's Women in Leadership strategy. Really, the aim of the formative research was to understand the barriers, the enablers, and the opportunities that exist for women, especially from marginalized groups, to grow into leadership roles. Specifically, our research question also aimed to look at not just the structural and institutional and contextual barriers and enablers, but also what does it take for women to be able to exercise their agency and influence in those leadership positions. This study was done in India, and in India, we specifically focused on UP and Bihar. It was also done in Kenya by our APHRC colleagues. In India, we looked at organizations and employees working within the formal health sector workforce. And the reason why I'm specifying this is because this study does not include community health workers, because they are not officially included in the formal healthcare workforce, which is really unfortunate. Next slide, please. So we did three things. We adopted three methods in our study, and we used the socio-ecological framework because women don't exist in silos, systems don't exist in silos. So we looked at factors at the normative, structural, organizational, and individual level. We adopted three methods, and today I'll focus specifically on our organizational review, but we also looked at laws in the country, and we did a legal content analysis of what these laws are. What do they say? Do they enable women? Are they creating barriers? And we also looked at existing published literature. Those are papers that are under preparation, but today I'll focus on the findings from our organizational review, where we did interviews with staff of around 19 organizations in India, and we also looked at their workplace policies, and we looked at their workforce data. Next slide, please. So in the organizational review, like I mentioned before, we looked at barriers, enablers, and opportunities. We looked at gender distribution along the career pathway within organizations, and we looked at their policies. We began with doing an extensive mapping of the health sector, and I'll come to this a little later. We approached around 30 organizations, out of which only 19 agreed to participate. These were around 5 international NGOs, around 10 NGOs, 5 in UP and 5 in Bihar. We were hoping to do more autonomous bodies, but only 2 agreed. We were also hoping to do more private sector bodies, but only 2 agreed. So we were able to speak to 19 organizations. We did around 48 interviews with these organizations, spoke to the organizational heads, spoke to HR managers, and we spoke to mid and senior level staff, men and women. We also interviewed subject matter experts who are bureaucrats, who are heading CSOs, who are academicians, and also researchers. And out of these 19 organizations, only 8 shared their workplace policies with us, and only 9 shared their workforce data with us. Next slide, please. So, like I was mentioning, we began with an extensive mapping of the health sector in India, and that was really a struggle because health sector is really vast. It has several streams. There's the public, there's the private, there's service delivery, there's also training institutes, and there are large number of actors, organizations, institutions, regulatory bodies, and wide range of disciplines and professional cadres. And there's a lot of interprofessional hierarchies between different streams of the health sector. Given the timeline of the study, given resources, ultimately the most feasible thing for us to really do was focus on the allied health sector. We didn't look at service delivery. Service delivery, some of the findings we did get through existing evidence, but we basically looked at NGOs, INGOs, autonomous bodies, and private sector. We began with the hope to do the public sector, but currently in India, that's a big challenge, getting permissions, getting approvals. So that's why our study focuses on the allied health sector. Next slide, please. So as I was listening to Rosemary and Rupa, I was thinking about this slide of mine, and I was thinking, okay, she's spoken about this, she's spoken about this, this is covered, this is covered, this is covered. That actually really shows how universal the problem is, right? So I will not go into details about the individual level or also so much about the societal level. That does not undermine the importance and the crucial need to look at gender norms and how pervasive they are within institutions, within people, and within work cultures, right? But the thing that I want to really focus on from our sort of study is the organizational level barriers and enablers. So some of the things that really stood out for us is this whole question of masculine work culture. This is something that we all often speak about. We say that organizations are not feminist in principles. They don't stick up to feminist principles. But what does a masculine work culture really entail? And through our interviews, while speaking to men, while speaking to women, we found that it's like a series of microaggressions. It begins with not listening to women in meetings. It begins with passing sexist comments around how they dress. It begins with telling women that, you cannot balance care and office. If women choose to take leave, women are told that, they are not competent enough. It begins with commenting on women being very young and using sexual favors to advance in their careers. So it also goes up to what women bring in their lunch boxes, right? So that's the kind of microaggressions and sexism that we are talking about. One female participant shared that she was at an office party and she was going to get a drink, and someone told her that, and it was a young woman, and someone told her that this is your age to have milk and not drink, right? So it goes up to, so these microaggressions are all pervasive. And I think that is at the root of inequity that women face at workplaces. Our participants spoke about motherhood penalty that Rupa highlighted. They spoke about lack of support from seniors. They spoke about complete ignorance about how gendered society is and how women have to constantly fight between proving that they are a good worker, but they're also a good wife, they're a good daughter, they're a good partner, so on and so forth. And another thing that was really highlighted, and that again connects back to my point to microaggressions, is the presence of boys club, which is linked to a lack of networking opportunities. Many women shared that women, and even men shared that women don't have access to networking opportunities. After office, women have to travel back home, they have household responsibilities, care responsibilities, so on and so forth. So women are not able to join these informal gatherings post office, and women, these informal gatherings are often where ideation happens, where information sharing around projects happens, where some decisions are made, and women miss out on all of that. That also is tied to this culture of men sort of dominating how things run at the workplace. I think while all of this sounds very cynical, a lot of our participants also spoke about what works. And in terms of what works, the most important thing to highlight here is that along with gender inclusive policies around maternity, around POSH, around childcare, around flexible working, menstrual leave, so on and so forth, what really works are informal measures, creating spaces within organizations where women are heard, where people from gender minorities are heard, where people with different backgrounds are heard, where some organizations had made forums for women, some organizations had made forums for young people to be heard. Then also having supportive supervisors, where supervisors are not, they just don't encourage you to perform well, but they also support you. They understand what you need to perform well. So there's a difference. A participant spoke about the difference between just encouragement, but providing actual support in terms of granting flexible leave, in terms of supporting work from home, in terms of understanding that there are conflicting commitments that women have, and also helping women express their vulnerabilities. What also really helped some of our participants was the fact that their seniors were women. They had role models to look up to who may have gone through similar struggles, who may have overcome them, and who were also vulnerable and open in terms of sharing it. So I really wanted to highlight some organizational level initiatives. And the other thing that I really want to also highlight is career development opportunities, not just in terms of attending conferences or attending training courses, but also in terms of just sort of being able to skill yourself up and going to your manager and saying that this is what I need. I'll just take 2 more minutes. Next slide, please. So to quickly summarize, along with written policies, informal measures have really made a difference. They've created a positive work culture, which is different from a masculine work culture. Younger women were more critical about organizations. They speak more to societal barriers. We found that men are just not sensitive to the problems that women face. Men constantly say that, yes, women have these problems, women have double responsibilities, so on and so forth, but we have these policies in place. And we also found very disturbingly that despite working on issues of gender and health, people like us who advocate for gender equality, these organizations are also not equitable. Next slide, please. So finally, key takeaways really are that there is no fixed leadership style. It's not, and it has nothing to do with gender. Women and men appreciated leaders who were firm, but who were accommodative, who were responsive, and who were caring and kind. At the same time, we also found that there was judgment for women if they were being assertive, but there was also judgment if they were not being assertive. I just want to end with one example. Next slide, please. So we spoke to 19 organizations, we spoke to 48 people. We found that a couple of organizations stood out, and these were organizations that ticked most of these boxes in terms of having gender inclusive policies, in terms of having informal measures, in terms of investing into building a gender inclusive work culture. Next slide, please. And this is my last slide. In terms of the next slide. In terms of the participants we spoke to, one person's journey really stood out, and she was very happy and she was sharing about her journey. And for her, this tallies to what we presented about organizations. For her, what worked was access to quality education and mentors, support from her partner, support and encouragement from her supervisors, opportunities for capacity building and networking, and inclusive work policies, but also very clear work policies. I'll stop here.
Thank you, Sapna. That was a very interesting presentation in terms of really a focus on organization culture, and also the fact that we also need to be inward looking to see where we are as advocates of gender and health, where organizationally we are pitched. So I understand that we are 1 or 2 and we have half an hour left. So I just want to take 1 minute to ask all 3 of you the same question. From 3 presentations, the one thing we take away that enabling either gender equity or a gender responsive transformative leadership in health is not an easy problem to solve for. It is multidimensional, it is multi-pronged, right? Going from structural to some very practical issues. So yes, I want to end this seminar with a note of hope and the ability for us to take some action. And that's why the last question to all 3 of you, and I'm going to give each one 2 to 3 minutes to respond to this, which is to say, what can we take away as some easy entry point to at least begin working towards enabling gender equity or gender equity in leadership in health, particularly in LMIC, in contexts that are resource strained, that have little political will at this stage of the journey. So what are those quick, I know this is not the words we want to hear, but it'd be great to know what could be some quick, easy entry points to even just think about. And so I'll begin with asking Rupa to go first, and then we'll have Rosemary and then Sapna. Thank you.
Thank you, Priya. And I think you've answered your own question. There isn't really any quick method because gender equality, whenever you look at any of the estimates, estimates show that it's going to take anywhere from 50 to 200 years to achieve gender equality in our society. So I think, first of all, anyone we're trying to bring into the agenda, we must say to them, we want you for the long game. And as someone that is part of Women in Global Health, and our model is around collective action, I would very much say if there's the one easiest thing that you should be doing, we invite you to join the Women in Global Health community, form a chapter, be a part of chapter. It's really great to see colleagues on today's call all engaged in our movement in different ways. So being part of a community that can help you drive that societal change is really key. I mean, it's great, all of those that have tuned in and joined the Gender Collab as well in this community of practice. But I think really having a community to work with and drive collective action is really key. But to break it down further, there are a lot of themes from today's talk, and it's so great when you're on a conversation where each one of us can say, oh, what else I would have said is on Rosemary or Sapna's slide, or Sapna saying things that I've said and vice versa. So when you see all that kind of crossover, it's really great to see the synergies aligning. And what really stand out that I'd like to highlight is that gender equity and leadership cannot be attained by just focusing on the individual only. Too often we approach this from saying, let's train women, let's get women, fix women to fit into the systems that are made for men. But what we really need is systems change. And that systems change, as we heard today, is wider. It takes legal, social, cultural factors. It must also remove the barriers to that girls are facing, especially in some contexts in sub-Saharan Africa. It begins with education. In other contexts, it's about ensuring legal frameworks have teeth to protect women from sexual exploitation, abuse, and harassment. Those are taboo topics that we don't often address, but they are sexual exploitation and abuse, harassment, bullying are one of the top reasons why women leave the workplace or don't even enter it, or don't want the most senior role, or don't want to go into political decision making. And then following the ecological model, it was great to see it being represented in different forms in today's conversation. But we need to attempts to fix women will not work. We need systematic change across communities, institutions, governments, and really there isn't a quick fix solution, but there are some things that in our report we really emphasize, and it was some of these things were said, but I want to emphasize it on our end as well. Establish all women shortlists. Yes, all women, because there for first decades, and one could argue centuries, there have been all men shortlists. So if there is a leadership role opening up, make sure that we make it all women shortlists. Half quotas are great, but even go further, do rotational leadership models. There's a call out right now to have the UN Secretary General be a rotational leadership model, because the United Nations has never been headed by a woman. And yet we use that as a norm setting agency globally. Women need to get the chance to lead, and doing to set in motion this cycle where more women will inspire more women. And it's not just enough to have one woman. We know it takes at least a critical number of 30% to drive that big change. So we cannot say one is enough. We need multiple women and multiple forms of role models. The second is implement workplace policies that support women's lives. We heard a lot about normalizing paternity leave. So men are also exercising it, and men are seen as caretakers, as fathers, as having children, as having families. I am really shocked that we live in a world where men are not seen as part of the equation when it comes to family. When in majority of the households they are part of the equation, right? So we really need to shift the gender norms to share the burden of care, work equally between women and men, and create safe spaces, as mentioned in the text chat here about lactating mothers, recognizing that the default women worker in the health workforce, unlike the default man, support breastfeeding, support caretaking roles that can be later in life too. And the third part that I would leave with, and we are really coming out strongly on our report on this, is that mobilize men to practice allyship by leaning out. And leaning out doesn't mean disappearing from the meal, from the scene, but it means that, if you are occupying a senior leadership role, think about, who is going to be next, and are you mentoring a woman to go ahead and take that next role? Or, if there are opportunities that you're hearing about in your male networks that you're connecting with, are you putting women names out there to, make sure they're getting the support and are being rallied? So it's not only a women's issue. We cannot put the responsibility on the shoulders of women, but men are benefiting. They're getting the male bonus. And we need to have them not just, say I'm a he for she and mentor. They need to take active transfer of power steps. So to drive sustainable change, leaders of all gender in the health sector must adopt gender transformative leadership approach. Dr. Morgan has really talked about that, so I won't go into details, but power is, and transferring power and transforming it is really key in going to the root drivers. And my final word as we close is to remind everyone that although they may not be recognized or rewarded, women are the leaders in health at all levels of health systems. So recognize that the leadership exists. Last week, I had the privilege to go to the Women Deliver Conference, and Women in Global Health held our Heroines of Health Gala, where we recognize women that are often the unsung heroines of our health. And we recognized 12 women for the work that they do and gave them an award, and had policymakers listen to their key asks. And so I encourage everyone that is championing for women's rights and health as a right for all to share the stories of our Heroines of Health, but also look for Heroines of Health in your own community and bring visibility to the women leaders that are there. Thank you.
Thank you, Rupa. Can I call Dr. Rosemary Morgan to give us her reflections on this?
Sure. Rupa made a lot of really good points, and that's why I try not to repeat them. And I know when I hear all of the stats and all of the, the ideas on what we can do, it can be quite overwhelming sometimes and feel like it's an insurmountable thing that we're trying to address. But it's important to think about it in long term, 10, 20, 30, 40, 50 years, where it's the long term goal and gain that we're looking for. I was recently part of a hiring committee at my institution for quite a high level position. We had so few women apply, and then even then that the ones that did apply, they were so outnumbered, thinking about the qualifications. And I just know it's going to be different in 10, 20, 30 years as more women are entering education and public health and other degrees. I know this change is going to come, and then doing the work now to make sure when it does that we're ready for it. And I think it's going to, yes, it's going to take advocacy and community, but it's one organization at a time, like one community, one household at a time. So, thinking about it from the organizational level, getting leadership buy-in is so important to do this work. And then thinking about, I offered in my slides some very practical things that one could do at an organizational level, thinking about a situational analysis or an assessment and an action plan. And you can't do this without buy-in from leadership, though. And then that toolkit from Jhpiego, is a training, a module that could be implemented within an organization. So, and Rupa is absolutely right that we shouldn't be looking to fix women. We should be looking to fix the systems and structures. So we need this policy level change as well. And that's going to happen within our own institutions, by modeling what we want to see. Others will see that, and it'll become more of the norm, whether it's within our households or communities or within our institutions. So yes, it can sometimes seem like an insurmountable task, but think about the long term here and the change that's going to happen, hopefully, if we keep up this work and pressure in the next 20, 30, 40 years.
Thank you, Rosemary. Sapna, can I request you to come in with your reflection?
Thank you. Thank you so much. I've been trying to think what are some quick 2-3 things I can say. Quick is difficult, but I think it begins with, it's simple. I think it begins with having the intent to be a gender inclusive workplace. And for that, you have to ask women in your workspaces and other minority people, what is it that they need? What are the challenges that they are facing in accessing available policies? Women in our study shared that despite having maternity policies, despite having flexible policies, menstrual leave policies, they're afraid to avail those policies because they may be judged. So I think perhaps bringing in new things will take time, but a quick solution really is, are your existing policies, the ones that are mandated by the government, are they being implemented with the right intention? Are people aware in your organizations? And are they accessing those policies? And what are the challenges that they are facing? The second point I really, really want to emphasize is around male allyship involving men. It was quite distressing in our study to hear men say, if we ask them, do you think men's journeys are different from women? They'll say, yes, there are childcare responsibilities, but there are policies, these days. So the ignorance, or perhaps what we say, but looking the other way, of what men do, I think that we have to change. And that will only, I think the issue is that very often when we talk about women's leadership, we focus on mentoring programs, scholarship programs for women. I think we have to work on programs to make men more gender sensitive. And the last thing I just really want to re-emphasize is what Rosemary shared about organizational assessments. One of our recommendations in our report is that you need a gender toolkit for organizations, which talks about formal policies, which talks about informal measures that can be taken, which talks about working with HR. Very often, we often forget that HR is the starting point of an organization, and that's where women often face barriers. The ones who are joining back after a career break, the ones who are maybe have small children, or ones who plan to get pregnant, so on and so forth, or who are pregnant. So working with HR managers, this gender toolkit should have policies clearly about what a gender sensitive hiring panel looks like. It should talk about gender sensitization, and perhaps Jhpigo's toolkit around gender sensitization trainings can be used. Basic things like what it means for a colleague to be heard, what it means to be respectful in a workplace, what is sexism in a workplace. I think that toolkit, for many of us, these are obvious things, but like I was emphasizing during my presentation, microaggressions are all pervasive. And that's why you need a toolkit like this that organizations should be mandated to use. I'll stop here.
Thank you so much, all of you, all three of the panelists. This has been a very interesting, insightful conversation, and we've got plenty really to take away. I'm going to quickly hand over to my colleague, Deepti, for a few questions that we might have from the audience. I'm aware that we are short of time. Over to you, Deepti.
Thank you, Priya. Thank you all of the panelists for such an enriching discussion. We would like to open the floor for all the audience to jump in and ask questions. There's a lot of conversations that are happening around in the chat boxes around motherhood penalty and male bonuses. Would anybody want to jump in and ask a question to the panelists? We could have a few minutes of that discussion. Yes, Annie, we see your hand up. Would you like to go in? Thanks.
Yes, hello, and thank you from everyone. Some really interesting insights and I think further areas to develop conversationally as well. I put something in the chat that has been kind of playing on my mind the past couple of days around facilitating women's leadership sessions, particularly in different contexts internationally. And part of a sort of an obstacle that we keep on hitting is negotiating, being able to hold women-only spaces in particular institutes, because the bargaining becomes between, we would like senior men staff there, make of that of what you will, but it can be complicated to find those very basic entry points as well, in which women are trusted to be able to have conversations and understood that they need those spaces. And I just wondered if any of you had any thoughts in terms of, there is no, for want of a better term, a silver bullet here, but to be able to negotiate the importance of that in very patriarchal institutes, and whether there is any insight there. Thank you.
Would any of the panelists like to respond to that, please?
Yeah, I'm happy to come in a bit and just say that there are many organizations that we have seen in the course of the last few years. So Women in Global Health started in 2015, which is 8 years ago. And one of the things we've been really advocating for, and echoing what my co-panelist has said about the need for organizational level change, is creating space for women's networks within organizations, whether they're formal or informal. And I'm really delighted to see that some of the most gender imbalanced global health organizations, institutions have seen an increase of, whether they're women affinity groups. Sometimes these affinity groups or networks are not just based on a gender identity, but also on an intersectionality. So having women of color groups, women of, sometimes in some institutions, you can even go down to exactly the multiple intersecting identities, and things that those have been really valuable spaces, and not necessarily always, you can say truly a safe space, but they are attempting to create that. So we do encourage that being something that organizations support informally or formally as well. And then as far as, the other techniques we've used at Women in Global Health, is it really helps if the senior leader, whoever that is, the head of the organization, makes a public commitment on gender equality, whether that's on International Women's Day or another historical health day, and not only says that, oh, I'm a gender champion, I believe in the women leaders in my organization, but really some concrete things that they will drive in organization. And I want to echo the points that Dr. Kedia and Dr. Morgan have both said about the need for organizational change, having these toolkits, looking at the policies, and you can often leverage saying, it's not enough just to applaud women, and we often say at Women in Global Health, we've applauded health workers, women health workers a lot during COVID, but it's really time to break from the past and provide a new social contract. So using those moments, which are often window dressing moments of like, oh, it's International Women's Day, we'll do a round of applause of all the amazing women, but saying, no, we're going to use these as inflection points to say, how are we progressing on the agenda for women's leadership and for gender equality? Thank you.
Thank you. Thanks.
May I come in just really quick? And I was just thinking, Annie Mae, about like real practical things that one could maybe do in that situation. Especially, I agree with Rupa that these spaces are really important, to have women-only spaces to talk about this. And if you're receiving pushback from individuals in the organization, is to get the buy-in and support from leadership and have that very clear to everybody. And then it also made me think about approach of in participatory action research that we take, that having these separate groups, but then having spaces to come together. So thinking about if you were, if there are men that do want to be involved, and we absolutely need male allies and need to have them involved, and that can lead to very uncomfortable conversations. I've had some of those myself, but to have a place where you have these women-only groups, and then make sure it's very clear you have points to come together with others in the institution to discuss and to talk. I'm just thinking really kind of real practical things that you might be able to do in receiving pushback and wanting to make sure you can have those safe spaces.
Thanks, Rosemary. We can take a question from Priyananda. Why don't you jump in?
Thanks, Dipti, and thanks for a fantastic panel, OPM and ICRW. I couldn't have expected anything less. I wanted to comment on the issue of backlash that Annie talked about, when I was at ICRW for about 10 years, we were helping Gap Inc. develop and execute its signature program called Planning Ahead for Women's Career Enhancement. It was called PACE. It still exists. And it has been very successful and embedded in industry, in the vendor base of Gap Inc., like across 50 vendors in 11, 12 countries. I don't know what the statistics are today. Early days when we were designing the program, and Sunena was part of that, she might still be on the call, with Swasti, what we learned was exactly a lot of pushback, because these were women who were working on factory floors. They were garment workers, and their supervisors would taunt them every time they had to go for their, like if I was a Tuesday batch or a Wednesday batch, I had to go for my training, because you were actually leaving for 40 minutes, the work on the assembly line. And what we realized is that with this continual pushback to women, that what we really needed is that we needed to create a program which was much more succinct and concise, which was for men, so that one, they understand what we're doing and why we're doing this, but also for them to not feel like they are completely isolated from this whole idea of building an enabling environment. And in a way, you are assigning accountability to men. So it was called the Key Influencers Program. And it was a really important facet of PACE, but we only did that in the second year once we understood this. So I just wanted to share that example. I actually have a question. This issue of women having to, their clock stops when they leave for maternity, and when they come back, often reintegrating is not easy, because it's not just the fact that you need breastfeeding corners or, creches when the child is older. You've actually missed out on very significant period of your work, and you don't have enablement to reintegrate. And there's a lot of isolation that women feel in that time. So I think there is this idea, the culture of the organization that others are talking about, that actually promotes women's reintegration back from maternity, back into their work, maybe buddying, having a buddy system. And that could be a very important part of the audit that somebody else had suggested on chat. But I do think we need micro interventions that are much more creative and fit for purpose for very, very specific things. And I think Sapna was saying something similar. So I just wanted to say that. And if others had any ideas and anything that's come up in like as global standards, would love to know that. Thanks.
Thanks, Priya. Would anybody like to respond to that?
I want to echo what Priya said about the GAP program. Priya, also in our experience of running the gender equity movement in school in GEMS, we've often heard if the program aims only for girls, we've heard that boys are complaining. If it aims only for boys, we've heard that girls are complaining. What we found is that within all programs and interventions, it is always useful to have separate spaces, but have points within programs where we bring them together through joint workshops, through campaigns. One of the things that we've also learned and suggestions that came from our participants is that, do trainings of male supervisors, organize training sessions of men who are managers, executive trainings. And that's what I meant when I was saying that we target most of our interventions towards building women's self-efficacy, to talking about imposter syndrome. All of that is important, but we have to also break the biases that men hold. And I think as managers, because they have decision making and they have power, it's important to think of gender sensitive executive training programs or gender responsive executive training programs. In terms of the career breaks thing, in the course of our study, I was just reading online and I found that organizations like PwC, and I was pleasantly surprised, they have a Bring Back to Office program where they have allocated their budget to train, to skill women who've been out of the workforce or have been on career breaks to train them on, say, latest softwares, latest sort of tools, so on and so forth, so that they're able to reintegrate them. So when they're hiring these women back, they have a 6 to 8 months period of reintegration. And this is budgeted in their sort of financials. I think this is where perhaps the role of the donor community comes in, where they support financial support towards reintegration. I think very often, while I spoke about intent, we also have to speak about financial resources and how donors, one, can drive these changes and can also demand accountability in the process. So for smaller NGOs, initiating some of these initiatives is very difficult. There they need donor support and patience. But for bigger NGOs, the gender audit, where you're holding them accountable, becomes very crucial. I'll stop.
Thank you, Sapna. I'm sorry, I'm just a little afraid that we have limited time. I'm so sorry to also cut off while we are having such an enriching conversation. Bhavnish, would you like to just drop your question in the chat box? I think we would try and see how we could address that. Thanks for the entire, all of the insights that you brought in, Sapna, Rupa, and Rosemary. I would just like to invite now Pranita as our co-hosts. ICRW has played such an important role in bringing everything together here today. Would you like to give in some closing remarks as we call this session? Thanks.
Thanks, Dipti. And I'm really sorry for being the person to really stop this very enriching conversation. First and foremost, I would really like to applaud OPM for setting up this gender collab with Quicksand and bringing partners together to work towards advancing gender intentionality within health sector. And I really urge all the participants to join the collab and contribute to the agenda, because this is definitely, the issue is close to everyone's heart, at least all of us who are here. I would like to thank Rupa, Rosemary, and Sapna for sharing this powerful, nuanced insights from your work on women in leadership and health. Very inspiring. Thank you all. Just briefly, some of the key takeaways, things that just stayed with me. So one is everybody agrees that health sector is where more women are entering. But also that their progression trajectory is not the same, especially about the who have the space to be on the decision-making table. And here I would say that we really look at the way occupational segregation is happening within the sector, because the first is that not everybody or all occupational sectors have space on the decision-making table, and the ones who have, women's entry in that sub occupational category is not very much there. So I think that's really important. So we need to really have those discussions, like even when women are entering, where they are entering, and who has the space on the decision-making table. The second part of that is that even if women have the space on the table, do they really get the space to talk, inform the processes and decisions? So barriers are multiple at multiple stages that need to be understood and examined. Rosemary talked about steps that could contribute in addressing barriers, the whole issue about normative barriers, how these norms are being reinforced and supported by systems and structures. We really need to understand that. I think to some level, we do have that understanding. I think the bigger challenge is to really translate these understandings from paper to on the field in terms of operationalizing, translating within the systems. And there we have to also recognize, and one of the speakers have talked about, that how some people, if not all, really gain from the status quo, and how to bring them on the table to be the stakeholder, to ensure that, and for them to also understand that it's not a zero-sum game. And every time I feel that whenever we have this discussion about women in leadership, we don't have the current leaders. And I'm talking about the people who are holding and they are not women as of now. They need to be on the table. They need to be part of the discourse and discussion. I do recognize that women really need exclusive space to move to the trajectory to inform the decisions, but without the current leadership on the table, facilitating and ensuring it's extremely difficult to move the path or to move the needle that we all aspire to do that. Another thing I say that, education system. So one is very important, the work that need to be happening at the organization level, at the policy level, and both the national policy and probably the global arena, but also within the organization. But what about the education and school system, which is really creating the pipeline? I mean, are we really creating enough aspiration among girls and the society's aspiration for girls? We really need to work about changing the perception on the unpaid care work. I mean, it's important to have the infrastructure, but that won't be sufficient. Otherwise, women will keep running from their office to pick their child, even if there is a crash. So, how to really change some of those scenarios, that is really important. Sapna talked about mentorship of young career women, but then it has to be 360. The system, the whole ecosystem need to really work to enable young women to progress. And in that space, I think we do understand there are evidence in research, but I think we need more research from the perspective of solution. What is and what can work, what is not working, how to really build on, leverage on that. And there's really a need to have more rigorous, system-oriented, holistic research and evaluation to understand that. There are so many questions about why women are leaving, what can really enable women to stay, re-enter all the points that we just discussed. I think these are very crucial, and we really need to have more research, which also means that we need to really look at this issue in a way urgently with identifying these entry points, but also have a longer term vision to really address many of these issues and make these reality on ground. And that really requires investment. And I really appreciate in BMGF and probably other donors really putting the resource, but this is a bigger agenda, and donor community, but also government and the larger global platforms, agencies really need to come up on this issue, and probably we collectively have to lead and bring them on the table as much we can. So with these words, I like to thank all our speakers, OPM team, Quicksand, ICRW for this webinar, all our participants to be here and enriching this whole conversation. I see chat box really moving, and as someone had earlier said, that all these discussion and the presentation will be available for everyone. Resource links are being shared. I think we need to continue this conversation beyond this webinar, but thank you everyone. Thanks.
Thank you. Thanks, Pranita. Thanks for really summarizing the key takeaways. Over to you, Rohan, in terms of closing the session. Thanks.
Thank you, Deepti. In the spirit of leaning out, I would like to invite my colleague Ria Gokharu from Quicksand to close for this evening. Thank you.
Thank you so much, everyone, for such an insightful session. I personally have a lot to learn from and also a lot to share with all of you as part of documentation. As I mentioned in the chat, that all the documentation and video links would be available at gendercollab.co.in. And we'll also intimate you once we have all of that ready through your emails. Yeah, I guess thank you once again. Gates Foundation, OPM, and also Renuka, who also helped us facilitate a lot of discussions around how to sort of conduct this session. And yeah, thank you so much.
Thank you. Thank you, everybody. Thanks.
Thank you, everybody.
Thank you.
Have a good evening. Thanks.
Yes. We'll be in touch. Bye.
Bye.